The cradle of stroke treatment is the IV lytics, invented decades ago, invested a couple of times in various studies. So history is IV lytics. When mechanical thrombectomy came up, it had to compare to the gold standard, the lytics. And the full potential of mechanical thrombectomy alone hasn't been investigated. This is what SwiftDirect is about. To compare bridging thrombolysis is mechanical thrombectomy non-inferior to this direct mechanical thrombectomy.
SwiftDirect was an international randomized controlled trial, and we had 48 sites in Europe and North America, and patients were randomized either to bridging thrombolysis or to direct mechanical thrombectomy. And it's very important to emphasize that we studied this protocol only in so-called mothership patients, which means only patients with direct access to endovascular therapy were included in the trial. Overall, there were 408 patients randomized, 201 patients were in the direct mechanical thrombectomy arm and 207 in the bridging arm.
The primary endpoint of the study was the modified ranking scale after 90 days between the bridging thrombolysis plus mechanical thrombectomy, the gold standard, compared to direct mechanical thrombectomy. And the study has shown that, first of all, the clinical outcome in both arms was very, very good. Also in historic comparison to previous trials, but was the better end for the bridging thrombolysis with 65% compared to 57% in the direct mechanical thrombectomy arm, which was not able to show non-inferiority of the treatment arm. What we saw in the clinical outcome also correlated with the recausation rates. We saw very high recausation rates in both arms, core lab controlled, with 96% with bridging thrombolysis and 91% for the direct mechanical thrombectomy arm. So very high recausation rates, but with a better end again, and in correlation with the mechanical thrombectomy IV lytic arm for this arm.
If you compare the results of SwiftDirect with other previous stroke trials, it is really striking to see the high rates of reperfusion and the very high rates also of good functional outcome. The potential explanation is that we had a standard treatment approach, which means we had one device only, which was Solitaire devices or generation of Solitaire devices. We also encourage people to use proximal protection devices such as balloon-guided catheters, and we also encouraged all physicians to give lytics, full lytics, whenever possible. So we asked them not to stop intravenous thrombolysis when they achieved full reperfusion. SwiftDirect was not able to show the non-inferiority of the direct mechanical thrombectomy compared to bridging thrombolysis. So this means that in clinical practice, there is currently no indication to skip tPA in patients who are eligible for tPA. Especially also the fact that rates of symptomatic intracerebral hemorrhage were very low in both treatment arms. On the other hand, you also could start thinking what we have done if endovascular therapy would have been invented before and intravenous thrombolysis would have been proven to be effective afterwards. So we would have done a trial adding intravenous thrombolysis on endovascular therapy. And then the question comes up, would we now change clinical practice and add intravenous thrombolysis on top of endovascular therapy? We are aware SwiftDirect was not powered and designed to answer this question, but this is something which we have to consider for the future.
I think what SwiftDirect has nicely shown is that the recausation rates with the current setup can be extraordinarily high. So the room for improvement is pretty low. The clinical outcome is very good as well. So where's the room for improvement for interventions? I think there are certain directions. One is we're going more and more into distal vessels. We probably might be faster one day. But one important topic is right now we're concentrating on everything. TICI 2B and 3 is a good recausation rate. And there's a tremendous difference in clinical outcome with TICI 2B and 3. And the future might be that every patient who has not recanalized to TICI 3 might get an adjunctive treatment like the intra-arterial thrombolysis. There are plans for studies like this. One of them is the techno trial in which we're going to apply tenecteplase after non-full successful recanalization, so everything below TICI 3.
We were not the only one running trials comparing bridging thrombolysis with direct mechanical thrombectomy. And as you know, overall, there are now 6 randomized controlled trials addressing the same question. And what we are doing next, we are pooling the data of all these 6 trials in individual patient data meta-analysis, and we will see whether there are any subgroups which might have a benefit of either combination therapy or direct mechanical thrombectomy. So the plan for the future would be that we can individualize our treatment decision based on subgroups.